Yeah, thank you very much. And I'm delighted to be here, and I would like to thank ODI for supporting me to be here this morning and share the story for Sierra Leone. And
just press this one. Just press that one. Yeah.
all right. Now, so we've already heard from Fiona about Sierra Leone. I like this slide because it actually puts a very beautiful face on neglected tropical diseases, but also what you don't see is the hidden stigma. I mean, the woman there with elephantiasis, and also underline that there are some mental health problems because of marginalization and issues like that. But because neglected tropical diseases like lymphatic filariasis don't kill people, it is not associated with a high mortality rate. People don't recognize the other morbidity issues associated with mental health and stigmatization. But again, Fiona did talk about 29 million community health, community drug distributors, 29,000, sorry, community drug distributors in Sierra Leone. And so the main strategy for controlling and eliminating some neglected tropical diseases, for lymphatic filariasis, the target is to interrupt transmission by 2020 in 73 endemic countries in the world. So these volunteers, community drug distributors, are very important, and I think in 2013, over 2 million treatments were delivered to over 600,000 people in Sierra Leone. Now, this is again just another version of the impact that Fiona presented. All I want to show you is that the graph, the endemicity map on the left of the slide, it shows that the entire country was endemic for lymphatic filariasis before mass drug administration started, and then 3 years later, only about 1 or 2 implementation units, these are districts, were still having the cutoff point of above 1%, which you need to continue mass drug administration. Now, this is a huge success. And the Sierra Leone program, which is also managed by Helen Keller International, and Dr. Yao Bizang is here from Helen Keller International. He's really involved in the coordination and guiding the program there. Now, the Liverpool School of Tropical Medicine, where I work, as you know, as Director of Neglected Tropical Diseases, our involvement in Sierra Leone, where I am from, is mainly to support some operational research issues to answer some of the questions associated with why is this program very successful. And the support for the program in Sierra Leone of operational research and monitoring and evaluation is provided by DFIC. Now, it's why is Sierra Leone so successful? I mean, it's had a share of bad stories. So I think I appreciate that we can talk about some success stories here today. In the 1800s, it was considered the white man's grave. It was a no-go area. And the significance of that, I'll tell you later. It's also associated with a high mortality rate for expatriates who went there. This included governors, bishops, and generals in the British Army. And but again, as I'm talking about the bad stories of Sierra Leone, which makes Sierra Leone famous, it's got one of the highest infant mortality rates in the world for many years. It had the lowest human development index, one of the highest illiteracy rates in the world. So I think I really appreciate the fact that we have an opportunity here to talk about a success story associated with what was known as the white man's grave. So what I'll be discussing is that how did Sierra Leone do this? Sierra Leone is definitely, the program for controlling neglected tropical diseases is considered one of the most successful in the world, not only in West Africa. Because if you see that a country like Ghana took over 10 years to achieve the reduction in endemicity that Sierra Leone received in 3 years, this is really a remarkable story. I think it's got to do with public health sensitization in Sierra Leone starting in the 1800s because of its association with the Liverpool School of Tropical Medicine. Very early government commitment, also in the early independence history that I'll allude to a little bit later. It started as an integrated program because there was Onchocerciasis control program, river blindness program going there beforehand. And it's also embedded within the health system using cross-sector approaches. But I like the story with early links of the Liverpool School of Tropical Medicine, because Ronald Ross on the left there got the Nobel Prize for describing the life cycle of malaria in 1902. But this was 4 years after he had actually gone to Sierra Leone to start the first community-based malaria control program. Now, if we know the story a little bit about Ronald Ross, was that his research on malaria was actually on bird malaria. And he was actually using Culex mosquitoes, not Anopheles mosquitoes. So when his story was published, the Italians then were working on Anopheles mosquitoes, and they came out, well, look, we all know now that malaria is only transmitted by Anopheles mosquitoes. So they said, wow, you are not really looking at the right mosquito. We are leaders here. We have been able to show that Anopheles mosquitoes are the only ones that transmit, and what you were working on was bird malaria. So Ronald Ross said, okay, well, I'll try and demonstrate that in the field. And where does you go? Where do you go in a situation like that? Is where a lot of people die. So he decided to go to the white man's grave. And in Sierra Leone, he was able to demonstrate for the first time that actually you have this transmission by Anopheles mosquitoes going on in the field. And also he started the first vector control activity against malaria that was in Sierra Leone. And then the Liverpool School then built their first field laboratory in Sierra Leone, and then working in that lab, they also established the life cycle of river blindness in Sierra Leone by Professor Blacklock. So there's been a strong link to that. Now, the other thing about Sierra Leone is that if you look at the history of Sierra Leone, the colony of Freetown, Sierra Leone, was actually established for slave trades, or for free slaves that were recaptured slaves. So Freetown was for the recaptives, and the settlers went there. So like in Liberia, some of the educated people that started running activities in this country were from the resettlers community. But the beautiful thing about Sierra Leone is that even at that, the first Prime Minister of Sierra Leone, Samuel T. Magai, was from the provinces, and when he got his medical degree, he actually worked in the provinces as an indigenous Sierra Leonean, and then he introduced a lot of public health activities before he became president. And the first foreign minister in Sierra Leone, John Carifa Smart, who later on became professor at Harvard, before becoming foreign minister in Sierra Leone, was also a professor of public health working in Nigeria. So Sierra Leone started early in its public health history, after its independence, with a lot of government commitment, people who understood the value of public health. So now, if we then go to how the other thing that makes Sierra Leone successful is the community-based approach to that. So there were integrated strategies. So all the diseases that Fiona alluded to, lymphatic filariasis, which is elephantiasis, schistosomiasis, soil-transmitted helminths, and river blindness, which is Onchocerciasis. Now, before the war, there was control methods going on in Sierra Leone for many years targeting river blindness. And this was before the civil war that started in 1993. But then, as soon as the war finished, the government was able to initiate a neglected tropical disease, an integrated program which builds on the successes of the Onchocerciasis program. But also, you'll see that Sierra Leone, the paper that I cited with high coverage of mass drug administration for lymphatic filariasis in rural and non-rural areas. It has been very difficult to actually achieve high coverage in urban centers, especially national capitals for countries like Sierra Leone. This is Freetown or Monrovia or Accra. How Sierra Leone was able to achieve a very high coverage in Freetown was involving like the national immunization program. So there were cross-sector approaches, building on all the social mobilization events, linking their drug distribution with what the immunization they was doing. And through that, they were able to achieve high coverage. And also, they were working with the maternal child health week, which involve distributing bed nets and a lot of issues that also contributed to social mobilization and getting the community aware. And so piggybacking drug distribution on that was able to, Sierra Leone, Freetown was able to achieve a very, very high drug coverage. We're talking about over 90% treatment coverage here. Before that, no capital city in Africa had been able to achieve more than 50% coverage. So these are very encouraging things for Sierra Leone. Now, so to just summarize what we've been doing in terms of what is responsible for the successes in Sierra Leone, I think in the political commitment that came from the early leaders, the first prime minister of the country, the first foreign minister of the country, both medical doctors, both trained in public health. Samuel Magai actually went to the Liverpool School of Tropical Medicine. So there was information about public health and the value of public health since the creation of the independent Sierra Leone. And then also we've said about the link between Liverpool School of Tropical Medicine and Sierra Leone, over 114 years of link that is still continuing today through support from the DFID. And also we have, I've said this about community-based strategies. Fiona alluded to 29,000 community drug distributors, and then we have cross-sector approaches which embeds the activities against NTD into the health systems that encourages social mobilization and that actually also improves coverage. Thank you very much, and that's our story from Sierra Leone.
Moses, thank you. That's clearly a link that has both enriched the Liverpool School and Sierra Leone. Could I just ask you, the historical perspective was really interesting, but I wanted to just ask you that if you took those two maps that you set up right at the beginning, 3 years before and 3 years after. I mean, what was the key determinant for that transition then? What were the cluster of factors that came together to make that change possible?
Two things. One, the previous treatment the drug that is used for river blindness is the same drug that is used for lymphatic filariasis. So before the war, there were pockets of mass drug administration programs targeting river blindness in a lot of areas. So by the time, this is started in the 1980s. So by 2008, when lymphatic filariasis program became part of the neglected tropical disease control program, the baseline disease prevalence was very low. So that's a very important component. So that was low. And then the second thing was, after the war, there was a lot of investment into development projects. So by the time Sierra Leone actually had its neglected tropical disease program, there was funding available from World Bank, from DFID, from all over there. So this really supported that change.
Thank you very much. So I'd like to move on now to Shilio Ariel.